Welcome. My name is Todd Heffern. I'm an emergency physician at the University of Tennessee Medical Center in Knoxville. Today we're going to speak on on-field emergency management of athletic injuries, and specifically with regards to equipment removal and spinal stabilization. I would like to thank multiple people from the University of Tennessee Athletic Department, Knoxville Orthopedic Clinic, and the City of Knoxville Fire Department for their assistance with this project. Just a few disclaimers that this presentation is based on the available evidence, position statements, and policies from multiple medical organizations in emergency medicine, trauma, EMS, and sports medicine. Also, this presentation is provided as information for EMS and on-field sports medicine personnel, but should never supersede your current standing orders or guidelines. So, starting with spinal mobilization, there's little, if any, evidence to support its use. There's also a lot of negative side effects associated with spinal mobilization, from just being incredibly uncomfortable to inhibiting respiratory effort, causing pressure ulcers, etc. Of note, we're not minimizing spinal care, just changing the approach that we take pre-hospital in potential spine-injured patients. In regards to athletic equipment, historically, the standard of care has been to basically tie the athlete down with all the equipment still intact except the face mask directly to a long spine board. The recommendations nowadays, though, are encouraging equipment removal as the equipment itself inhibits proper medical evaluation and care. So the objectives of the presentation today are, first, we're going to go over the history of spinal mobilization. Then explore some of the emerging evidence in regards to the positive and negative effects of spinal mobilization. Introduce what is becoming the new standard of care in spinal motion restriction and its application to spine-injured athletes. And finally, provide an introduction to the wide variety of athletic safety equipment and the methods to remove it. In the first video, we're going to talk about the spinal injuries and immobilization. So in regards to spinal injuries, there are about 17,000 new cases per year. And out of 30 million EMS calls, that's about 1 in 1,700 calls. And out of a population of 314 million people in the United States, that's about 1 out of 18,500 people. Most of these are due to MVAs and falls, with some coming obviously from assaults and violent acts, and 9% of these have been associated with sports injuries. But in regards to the 9% of these quote-unquote sporting injuries, the total would be about 1,500 per year, which would be an ungodly number just for routine athletic injuries. The problem is that the quote-unquote sporting includes a wide variety of activities, from diving to true team sports, to rodeo, to parasailing, snowboarding. So it's hard to extrapolate the actual number of what we would consider true on-field athletic injuries. So if we start looking a little bit closer at the true team sports, football has the highest number of cervical spine injuries in total. Cheerleading has the highest number of direct catastrophic head and neck injuries for high school females. But if you look at the incidence rates, high school gymnastics and ice hockey actually have the highest incident rate of catastrophic head and neck injury. When we look at the total participation numbers in sports, the NCAA has about 71,000 athletes, and this increases to over 7 million high school athletes and 45 million athletes involved in youth sports. Total, about 1.3 million of these athletes will visit an ED every year for some sort of sports-related injury. If we look specifically at spinal injuries in athletes, it's estimated that there are 250 to 300 athletes per year having a cervical spine fracture. However, only 9 to 12 of these will have some degree of permanent neurologic deficit. In fact, of the recorded injuries from 1977 to 2012, only 266 high school football players had incomplete recovery from a cervical cord injury. This is well under 10 athletes per year. So when we're standing on the sideline, either from a sports medicine role or a EMS role, or just because you just happen to be standing around watching a sporting event where there's nobody else providing medical coverage, when an athlete goes down on the field, there's obviously a large variety of injuries that they can sustain. Most of these injuries are going to be non-life-threatening issues that can be fairly substantial and debilitating. But at the end of the day, there's really two things that when you walk on a field are immediately life-threatening or life-disabling. And those are a spinal cord injury or a cardiac arrest. And generally, each of these is going to present differently. The spinal cord injury is generally a contact injury. So an athlete gets tackled and they're laying there not moving. They are generally going to be alert, will look at you, probably try and speak, but not moving their arms or their legs. Now this is going to differ from a cardiac arrest, which is generally just exertionally related. They may or may not get hit. Often these are just seen collapsing suddenly away from the play. These will be completely unresponsive and pulseless. And the difference between the two is with a spinal cord injury, you need to take your time to protect the spine. However, with cardiac arrest, yes, we do want to think about the spine, but the immediate need is to expose the athlete, get their equipment off, and provide defibrillation as soon as possible as they are likely in a life-threatening cardiac dysrhythmia. So the first thing we're going to talk about is the history of spinal immobilization, or how we got to the point of boarding and collaring everybody. So the origins of spinal immobilization seem to stem from a 1966 paper, which was a retrospective study of trauma patients who had developed a delayed paralysis. This delayed paraplegia was linked to a failure to recognize an unstable spinal injury. And the actual quote from the paper was that the people responding to the accident had the failure to recognize the injury and protect the patient from the consequences of his unstable spine. And this regarded a specific car wreck where the patient had a skull fracture and then had developed a delayed onset of paraplegia at level T4. This was continued with another quote saying the importance of proper first aid by EMS providers was deduced from the fact that 29 patients were noted to have developed further paralysis, supposedly through faulty handling. Now, the idea is put into the medical community that trauma patients should be immobilized on rigid devices to minimize this risk of delayed paralysis. So we advanced 2 years to 1968, where a study came out in the Journal of Trauma showing that using a backboard and a cervical collar prevented the head from sagging during extrication. They described the use of these devices as necessary during an extrication. Now, the backboard was designed to assist rescuers to help prevent spinal movement during complex extrication maneuvers, to help free up hands during these maneuvers, but it was not envisioned to be a long-term device to actually immobilize someone to after they were extricated. The first guidelines for EMS spinal mobilization came out in 1971 when the American Academy of Orthopedic Surgeons published Emergency Care and Transportation of the Sick and Injured. The paper advocated the use of spinal mobilization using a backboard and C-collar for trauma patients who had signs of possible spinal injury, pain, tenderness, altered mental status, injury to the head or back, and deformity. There was no mention of mechanism in this paper, and they recommended a simple range of motion test to determine whether or not to immobilize the spine. In 1979, in the Journal of Bone and Joint Surgery published a paper showing that 100 of 300 cervical spine injuries were initially missed in the emergency department. They linked these misses with delayed paraplegia and presented the concern that these injuries were being underappreciated. They had a knee-jerk response to blame EMS in pre-hospital care and put out the thought that based on mechanism alone, that backboards and C-collars should be used. Finally, in 1988, the first BTLS guidelines came out. These noted that even after years of research, nobody had devised a formula to predict who had an unstable spine or spinal cord injury that could be aggravated. The only safe course of action they felt was a constant suspicion and combined with proper patient handling and packaging, and basically created the thought that we're just going to package everybody. So all of this basically created this dogma of spinal immobilization. Trauma must equal a spinal injury. If it's a spinal injury, it's got to be unstable, and an unstable spinal column injury must mean there's a spinal cord injury. And if there's a spinal cord injury, you've got that risk of permanent neurologic deficits, and obviously those are bad. So if we use the powers of math, geometry, trigonometry, whatever you want to use, we find that trauma always equals a permanent neurologic deficit. Now, some of the facts that have kind of been passed down from these ideas are that any additional movement of the neck or back may cause an injury that was not there from the initial trauma, or it may worsen an injury that was already there. Further injury is avoided by completely immobilizing the spine. Another fact, immobilization of the spine is completely safe and harmless. And medical legal issues are preventing us from changing and getting away from full spinal immobilization. So let's first start by looking at some of the pros and cons of immobilization. Primary benefits, of course, being the stabilization of the spinal cord, thereby preventing either new or aggravating current spinal cord injuries. Secondary benefits are obviously assisting with patient extrication and movement, allowing easier restraint of agitated or combative patients, and providing a nice solid surface in the case of CPR. The problem with this is there's never been any randomized control studies truly ever done, and the quality of evidence behind these facts is suspect at best. So luckily there are some newer studies starting to come out. Now, one of these came out in 2009 in the Western Journal of Emergency Medicine. This study used motion capture video to compare 4 different extrication techniques. Obviously, the full C-collar, spine board head first with 2 paramedics. Also used a KED and C-collar with standard technique. In addition, they placed a C-collar on the patient and let them self-extricate, and they allowed the patient to self-extricate with no equipment. And what they documented was the least movement of the cervical spine was in subjects who had a cervical collar applied and were allowed to simply get out of the car by themselves and lie down on a stretcher. So a similar study came out in the Emergency Medicine Journal in 2014. This again used biomechanical sensors to monitor the patient's movement with 9 different extrication techniques. They used a self-extrication as a control, and then 2 paramedics and 4 firefighters were used with all these other techniques. And basically what they found was that there was 4 times more cervical spine movement during assisted extrication than just simply allowing the patient to do it themselves. Now, since the incorporation of long spine boards and cervical collars into both extrication and transport, there have been quite a few studies which are coming out looking at the negative effects of these devices. Obviously, you have aspiration and potential airway compromise. There's numerous studies looking at respiratory compromise and specifically showing that long spine boards reduce FVC and FEV1 in healthy patients, let alone patients who have substantial underlying lung or other chronic disease. Another well-documented side effect is pressure sores or pressure ulcers. Even with short periods of time on a board with healthy patients, and obviously this is going to be more concerned with elderly or severely injured patients who can't readjust themselves. Anyone who has either been strapped down to one of these boards or been around a patient for longer than 5 minutes who's been strapped to one of these boards understands that there's a good amount of pain that will actually develop just from the board itself, and often can lead to increased agitation or combativeness in patients who are already somewhat altered. Now, if we're causing patients to develop new pain that was not there after the initial injury, this does have the downstream effect of creating unnecessary radiation exposure from increasing testing, as well as the costs associated with these tests and admission to hospitals. In addition, the use of both the long spine board as well as cervical collar has been shown to increase intracranial pressure. Now we'll take a look at some of the emerging evidence and standards of care. In 2001, one of the more important studies regarding evaluation of the surgical spine came out. This was the Nexus study, which looked at a large number of X-ray trauma patients and found a group of criteria, which we now call the Nexus criteria, which allow for clinical rule out of significant cervical spine injury. Of the 27,000 patients that they looked at, only 15 of the 659 fractures that were present would have been missed using the Nexus criteria, and none of these had any neurologic sequelae. Now, one of the studies that really kicked off the debate of spinal immobilization came out in 1998 in Academic Emergency Medicine. This study basically looked at two completely separate populations which were treated with completely opposite ends of the spectrum in regards to spinal immobilization. One of these was in New Mexico, where every patient got full spinal immobilization. And the second was in Malaysia, where nobody received any sort of formal spinal precautions. What they found in this study was that it was actually twice as likely that the immobilized patients had a long-term disability compared to the unimmobilized patients. And they statistically found that 98% probability that immobilization is harmful or at least of no value. In 2009, the Cochrane database came out with a review of all the available evidence and basically found that the immobilization led to unwarranted negative side effects that we've already spoken about, in addition to risks of aspiration, respiratory compromise. Now we're going to look at some emerging standards of care from various specialty organizations. The new term for spinal immobilization is spinal motion restriction. And the idea is we are slowly getting away from using true immobilization on a long spine board. And the rationale behind this is that the cots that we use are essentially padded spine boards. And once the patient's secured to that cot, the backboard just becomes a redundant piece of equipment. The mattress can conform better to the anatomical shape of the spine and obviously is much more comfortable. And the other things that we have found, as we have discussed, is that an awake and cooperative patient can actually protect their spine better than any piece of equipment that we have. The other thing with spinal motion restriction is that obviously it reduces all the negatives that we've spoken about with a long spine board. So the Eagles are a loose organization of the 50 or so largest metropolitan areas and the medical directors associated with the EMS services in those areas. This organization came out with a position statement basically saying that current EMS protocols are based on historical precedent and not on true scientific evidence. The current best practices reflect that there are no randomized controlled trials to evaluate the benefits of spinal immobilization, and this is complicated by the fact that such studies are likely never to be performed due to ethical and legal concerns. They continue on, though, saying that there's a growing body of literature showing a lot of negative side effects of spinal immobilization, whether or not it's used appropriately. The National Association of EMS Physicians, in association with the American College of Surgeons Committee on Trauma, came out with statements in 2013 basically saying that if the patient met the Nexus criteria, that immobilization on a backboard was not necessary. They also added that patients with penetrating trauma without evidence of spinal injury should never be immobilized on a backboard. The strongest statement against spinal mobilization came out in 2015 from the American College of Emergency Physicians. This basically supported the 2013 recommendations, but added on that backboards should not be used as a therapeutic intervention or a precautionary measure anywhere, and supported the idea of spinal motion restriction to protect the spine without the use of a spine board. Moving into the athletic realm, in 2015, the National Athletic Trainers Association came out with an executive summary on the pre-hospital management of the spine-injured athlete. They came out with multiple recommendations. Specifically, in recommendation number 4, they state that athletic equipment should be removed prior to transport to an emergency facility. This was revised a couple months later due to some concerns over variations in various regional EMS protocols and manpower. They also recommended that equipment removal should be performed by at least 3 rescuers at the earliest time possible. Now we're going to talk about who needs what type of immobilization. I will preface this by saying that these are recommendations from the best evidence that I have, and that you should still always follow your local protocols. So the Tennessee State EMS Guidelines, which serve as a basic template for most of the EMS services, recommend that backboards should be avoided in conscious patients, that placing ambulatory patients on backboards is unacceptable, and do recommend their use with CPR. They also recommend the use of spinal motion restriction, which we have mentioned previously, which is basically the procedure of protecting the spine like we normally would, just not using a long spine board unless absolutely necessary. So why do we recommend equipment removal? Obviously, the EMS guidelines are changing to get away from long spine boards, and it's somewhat difficult to strap a patient down who has shoulder pads and a helmet just to the cot. Also, obviously, equipment limits access to your vital areas and the airway and the chest in case of a true on-field emergency. In addition, most EMS personnel, and I can speak personally from the emergency department personnel, have little, if any, experience with athletic equipment. And the people who know the most about that equipment are already on the field, generally with the athletic trainers and even coaching staff and parents. Also, equipment is very expensive, and many times the attempts to remove it cause permanent damage to the equipment, which either has to be repaired or completely replaced. So my opinion on this is that the helmet and shoulder pads should be removed prior to transport if at all possible. Also, EMS personnel must remember a certified athletic trainer, ATC, is going to be present at many of the high school games and is a valuable resource for not only interacting with equipment removal, but also in the knowledge of resuscitation of the athlete. Generally, the athletic trainer is going to be the first medical provider on the field. And once EMS arrives, there should be a plan in place to take care of the athlete. In general, the EMS personnel should take over primary care of the patient, maintaining spinal mobilization, and then the athletic trainer should be allowed to assist and direct equipment removal. These roles should really be defined before the game or even before the season, if at all possible. One thing to remember, if there is not an athletic trainer on scene, consider requesting assistance from coaches or bystanders who may be more familiar with the equipment. So what you see in front of you is the immobilization flowchart that I use for many of my EMS services. It breaks it down basically into 4 categories. One is obviously just complete spinal clearance where no mobilization is needed. You then have placing a C-collar and either allowing the patient to self-extricate or using spinal motion restriction techniques to get the patient and the C-collar onto the cot. The 4th category is obviously full classic extrication and spinal mobilization utilizing a long spine board. The problem with this, though, is with athletic equipment on, it's very difficult to place the patient again on the cot and strap them down without first removing that equipment. Now, this is where your critical thinking is going to come into play, because you're going to have to evaluate the patient and figure out which category they're going to fit in. And obviously that can be as simple as they're not having any neck complaints. They don't need any immobilization. If they're only having mild symptoms, then they may only need a cervical collar and they can get up and walk off the field themselves. Obviously, if they have severe neck pain or they have tingling or numbness temporarily that is resolved, they may need a more formal extrication using typical spinal motion restriction techniques. The highest acuity patients are also going to be the most complicated. These patients may include ones that obviously have some sort of neurologic deficit, such as weakness or an altered level of consciousness that is persistent, or obviously patients that are in active cardiac arrest. It's going to depend completely on the available personnel to remove equipment, as well as potentially other factors in regards to whether or not to take the equipment off. My recommendation is to always take it off if at all possible, but again, it is going to be very situation dependent. Just to reiterate, if you get on the field and the patient is apneic or pulseless, it is most likely a primary cardiac event, as a spinal cord injury is unlikely to cause an immediate cardiac arrest. The focus should be getting the equipment off as quickly as possible. Generally, this is going to be cutting it to provide CPR and AED placement, as well as possibly airway interventions. So part 2 of the presentation will involve the actual equipment removal.